I'm very happy and pleased that I can introduce Professor Dr. Hajo Zeeb. In Germany, you don't have to introduce him normally because he's very well known and also internationally, I'm sure. And he is professor for epidemiology at the University of Bremen. He's head of the Department for Prevention and Evaluation at the Leibniz Institute for Prevention Research and Epidemiology in Bremen. And also some results of his group have been presented earlier. He has got a very strong interest in social epidemiology with a special focus on migrant health, so well fitting to our topic today, and is coming directly from an UN meeting. So I'm also very happy to have you here, Hajo, and he will now host the panel discussion and moderate, and he will introduce our panelists. So Hajo, thank you.
Thank you very much. Now we hear this microphone, so it's my really thank you for inviting me to be here with you, and it's a really great pleasure to round up the whole colloquium in some ways together with you. It's not my task, I'm just helping to get it off and running, and we really plan to discuss with you. We will have obviously some, because we have very nice panelists here with us, we'll also give them a chance, but we also want to give you a chance to get into discussions with them, because after all, the topic of the afternoon is why should public health institutes, and this is our main public health institute in Germany, why should they care about health inequities? So this is you we are talking about in some ways, your institutions, many of you at least are working there. But there are also obviously institutes elsewhere in the world that may be, interested in this question. So that's our charge for this afternoon. And I would like to start introducing my colleagues here on the panel. And I would start with Stéphanie Vandentorren. She's online. Do we see her? Yes, we do see. Hello, Stéphanie, up there. Yeah, just behind my right shoulder, but that doesn't mean anything. You are very important for us here. You are the coordinator of the Health Inequities program at the French Institute of Health, Santé Publique France. She's a medical doctor with a PhD in epidemiology, much to my liking, obviously, and she obviously supervises PhD students, and she has also served in different regional divisions in the institute and in France, and she's a senior researcher in social environmental epidemiology. Now she's also leading a lot of epidemiological investigations related to health crisis, vulnerable populations. So our key populations here are much of her interest, and she has done a lot of interesting recent research also on the health and healthcare access of these populations, including incarcerated people in prison, homeless people, gypsies, and so really people that may sometimes be seen at the fringe of society, but that are very important for equity issues that we need to talk about. So welcome, Stéphanie. Secondly, we have Dagmar Starke here with us, heading the Academy for Public Health Services in Düsseldorf. It's a well-known public health training institution, and she has held senior positions there since 2010, I believe. And she studied pedagogic sociology and psychology at the University of Düsseldorf, and has been coordinating large projects in the past, including one very important one, the social variations in health expectancy in Europe. I think we talked about health expectancy during the last days as well, and that was headed by Johannes Siegrist and Michael Marmot. I think should be well known in these discussions here. And she's also worked in public health offices in North Rhine-Westphalia, and she was in charge of health policy at some stage in the Association of Statutory Physicians North Rhine. So she has got the whole baggage of the health services from many sides, and now very much in the public health service. And to my pleasure, I can say she's also a colleague in the board of the German Association for Public Health, in which I'm also serving. So welcome, Dagmar. Forgot to say that she's also an honorary professor at the University of Applied Science in Coburg. So probably there are many other things I have not said. Never mind. Once again, very much welcome. And then we have Benjamin here. Benjamin, most of you probably know him from the Robert Koch Institute. He's a research associate here at the Division for Social Determinants of Health at the RKC, and he currently coordinates a research project on socioeconomic inequalities in health during the COVID-19 pandemic. So he's a medical doctor, University of Leipzig, and he holds a master's degree of public health also from London School. And he did work as a physician, like myself. In the beginning of my career, I also worked some years as a physician, but then we've found many interesting other issues in the world. And fortunately, now he's working here as a social epidemiologist at the Robert Koch Institute since 2018, I believe. That much for a short introduction. So this is our group here, so representing different aspects of social epidemiology, let's say, in Western Europe for this, but fortunately we have also colleagues from other parts of the world here who have been discussing with you, and I think this is great. I will pose my first question to Stéphanie. So Stéphanie, I think it was also mentioned yesterday, and the data was shown that health inequities are also prevalent in France. So maybe you can give us a short insight into what role the consideration of inequities plays in French public health, and specifically perhaps at Santé Publique France. I hope you got my question, Stéphanie.
Could you hear me?
Yeah, we can hear you well.
Thank you for inviting me in this meeting. It's a pleasure to share experience about health inequalities, and especially in our institute. I think we face two structural problems to identify rapidly the health inequalities. And for example, during the COVID crisis, we have to take into account this point, but it was very difficult because there is no interaction between the social data and the medical one. So it could be a big issue for us to document how the health inequality was. And so as we don't have individual data, we have to use some ecological data with the social deprivation index, for example. But in my opinion, it's not really the more efficient way to discuss with the political issue. And so we have performed some. We want to improve that to move to the social deprivation index, to the more structural social determinant of health. And so it's a big issue. But during the COVID crisis, we have found two major issues, I think. The first one is we didn't have a social gradient, in fact, because it was more the last quintile, so the more deprived people who have paid the more difficult prevalence of infection, comorbidities, and mortality. So it's not really a gradient, like, you know, a very proportional gradient, but it was really a big issue for the last deprived people. And the second one was not only social and economical issue, but also its deal with ethno-racial inequalities. And so we have shown a big issue with the population from sub-Saharan, which have work in the frontline workers, and they have mortality about 9 points more than the native people. And I think these two major issues have modified the perception of the National French Public Health Institute to take into account more the structural social determinants.
Thank you. So that's already an interesting point, and we'll talk about it in a moment. Thank you for now, Stéphanie. Dagmar, you are leading the German Academy of Public Health Services and offering training for public health physicians mainly. So how important in that work is the topic of health equity for the training regarding equity issues? You know, is it an issue in your academy work? And maybe, because we're talking about the RKI as well, how important is material provided and insights provided by the Robert Koch Institute in that work?
Yes, thank you, Hajo, for this question. Good afternoon, everybody. Well, of course, health equity is an important issue in our trainings and everyday work, because the main task of local or public health authorities are to focus on people, disadvantaged people, populations at the structural level, as well as migrants, prostitutes, men having sex with men, and so on. So what we do is to raise awareness to unequal health expectations in all those groups, and as well to strengthen all our participants, not only physicians, but we have many others who are always working in the public health authorities. We are strengthening the awareness and supporting them to acting with regard to health equity and to having the different needs in mind that people might have. And of course, the data is more than important. We have a strong cooperation with RKA since many, many years. And Thomas Lampert, who was mentioned this morning, he was very often part of our trainings and was referring to people who are, who are exposed to poverty, and thus we do need your data. We do need better data and more data, also closing the gaps that have been mentioned several times. And I think we do need even more data, not only on infectious diseases, but also on NCDs. Of course, the data linkage between social determinants and mortality, but as well infectious diseases and NCDs as well. So,
and maybe just
cooperation.
Excellent. And just a quick question: are there eye-opening moments for people there that come to these trainings in the academy? Are people sometimes surprised about what they see when they, for example, look at the data? Is it an experience?
Yes, they're very often surprised. Well, they know they're working on the local level, so they know very well where are the streets or the places where people suffering from deprivation do live. But if they see the differences, like the analysis of Thomas regarding the mortality or life expectancy between high and low income groups, this is something that is always striking, and they start to think about it and what we can do. And this is what you see, what we've seen during the pandemic, that is, in the first time it was out of the focus. And afterwards, at least some of the cities started to think about, well, we have an unequal distribution of morbidity and mortality in some parts of the city, so we have to act and try to prevent.
Thank you. Ben, you are here at the RKI. You are an early career researcher and working on the core topics: social inequality, equity. Traditionally, in the past, major topics of Robert Koch Institute have lain elsewhere, one can say generally. Whatever that past exactly is, we can perhaps discuss. But anyway, what makes you confident that a high-level public health institution such as the RKA really engages in health equity issues now and in the future? And where perhaps do you see the future role of RKA? You can speak freely. Nobody is listening to us from
Yeah, thank you very much for this nice question, Hajo. And thank you very much for having me here. I'm speaking on behalf of my division of social determinants of health today here on the panel. And science keeps young, so early career researcher, middle of his life. But so what is a Robert Koch Institute known for? Perhaps we should name it exactly. So I think you are referring to our history as a Royal Prussian Institute for Infectious Diseases in our heroic past and present as well, with a focus on infectious disease research, and infectious disease epidemiology. But that we are sitting here today, and when I'm looking into the audience, I see a lot of colleagues from different departments and divisions, not only from the Department of Epidemiology and Health Monitoring, where we as a division are situated in the Robert Koch Institute, but from all departments of the Institute, and that we are sitting here today in a flagship event of the Robert Koch Institute, perhaps discussing health inequities, makes me confident that there is an acknowledgement in the Institute and the whole Institute of the importance of health inequities and its different aspects, which are important for our work. That would be the second point I would like to make, so to fulfill our work, so we have a certain statutory mandate as a National Public Health Institute that is broadly summarizing to detect, protect, and prevent from communicable and non-communicable diseases. And for me, it's impossible to think that we will effectively fulfill this task without mentioning and regarding health inequities. And so I'm confident that we will do this in the future. And perhaps as another point, would be the COVID-19 experience. So we have collaborated with a lot of other departments, divisions before, but the COVID-19 pandemic was something like a magnifier for us as well. So it augmented the collaborations between our division and other units in the Robert Koch Institute. And I'm really, I hope that this interest in health inequities won't fade out like the interest in the pandemic that we can see at the moment, but will continue. But yeah, I'm cautiously confident that will be the case, especially regarding the growing social importance regarding these topics, because we are seeing growing health inequities worldwide during the last years, on social inequities, which can lead to health inequities if we are not acting effectively. And so I think we have, besides these legal obligations of our mandate, we have some moral, normative, ethical obligations to deal with health inequities, because there's a lot of prevention potential inside health inequities. So perhaps to quote our Minister of Health, he said during the Qatar lecture in Harvard, when he was in Harvard, he showed these slides we have seen today. Claudia presented them with the life expectancy differences between men and women in the most and least well-off quintile. And he compared these changes, these differences in life expectancies wouldn't be there if all would have the same social status. With life expectancies gains, we could gain by effective treatment of all known cancers. It would be around 2 years. I don't know exactly where these numbers come from, but I thought that if I'm quoting the Ministry of Health, I should be on the safe side. I want just to show how big this potential for prevention is inside the population if we are effectively dealing with health inequities, and that makes me confident that we will do it in the future.
Right. So this is perhaps leading quite nicely to an issue that I found a bit surprising. I looked at the IANFI, the International Association of National Public Health Institutions, and I think Stéphanie is also close to them. So only in 2021, they had a statement, a real statement, where the IANFI urged its member organizations to place, promotion of health equity at the core of their work. And so I was wondering, social determinants really have been known to affect populations for, population health for decades, if not centuries. And I was, a bit puzzled. Why is it only in 2021 that such a statement comes out of this body that represents national public health institutions? So, I mean, obviously it must have something to do with COVID-19, but was it an eye-opener in that sense? So maybe I'll direct this to to Stéphanie in the beginning, and then maybe you can also say a word on this because you mentioned already that something happened there. But anyway, a bit late for my liking. So, Stéphanie, what would you say?
I think I agree completely. The COVID and the pandemic has highlighted the gap between what we should do and what we have done. And so I think we have some different issue at the international level, but also European one, to take into account more efficiently this issue. The first one maybe is the data collection, because we are not all able to monitoring the social determinants in our National Public Health Institute. And so we share this point with the other countries. Maybe the second one is a problem of in terms of action or prevention and promotion, health promotion. We are not always taking it into account the more deprived people. So sometimes we use the universalism, proportionate universalism, but not always. And there is a consensus that there is no always evaluation of this intervention action. So maybe we can share also this issue to know if we are efficient with the more deprived people when we are doing social marketing or a campaign from promotion and so on, because we share that for health equity, we need to have some universalism action, but also target action, because there is some people who are really marginalized. Sorry for my English, margins. I don't know how you say that, in social exclusion, in fact. And so we talk about health mediation, for instance. We think it's promising intervention for this group.
Thank you. Yeah, maybe the panel, Dagmar, Benjamin.
Yes, thank you. I agree totally that the pandemic highlighted the gap, but I would like to extend it, widened the gap. We can see this regarding obesity, for example, less mobility, especially in low income groups, in people living in precarious housing situations and so on. And what we do not have to, what we should keep in mind is that Claire Bambra introduced the model of syndemic. That means the pandemic does not only showed or we witnessed different mobility along the social strata, but also we have effects on other fields of health, less vaccination, routine vaccination, more pregnancy among young women below 18, tuberculosis, and so on. So I agree totally with Stéphanie that we do need a proportionate universalism, and I like the idea of the marmot cities. So we should think about adopting this idea in Germany, because there are many aspects that we easily could adopt and which go beyond the idea of the Healthy Cities Network. And the Healthy Cities Network is more focusing on health and all policies, while the marmot cities are focusing equity. And this is what we should keep in mind. So I would like to use the effect of the pandemic you said yesterday, act like an academic activist. I like this expression very much, and I think we should adopt it for us and promote the idea of marmot cities.
Okay, so you already made at least one point I wanted to make with the syndemic, so that's already said. But so yeah, I think it's the most important thing, perhaps, so that infectious diseases came more to or health inequities or inequalities in infectious diseases came more to the interest, were in the focus during the pandemic, and we didn't care so much about in social epidemiology so much about health inequalities in infectious diseases before. And so we had a lot of interest, and I think during this time also the publication system changed, and there was a huge interest and huge efforts from science, and so that transported as well social inequalities in infectious diseases to a broader public and in different fields of science. And I would love this might continue because I don't remember exactly who said this of our speakers, but so perhaps we need these pressing points of pandemics because NCDs are not so interesting or not so pressing sometimes, or regarded as not so pressing public health threats, but they are the biggest burden we have globally and nationally. And again, to make the point of prevention, there lies the biggest potential for prevention. And yeah, hopefully this interest in social determinants of health won't fade out after the pandemic is over, and will continue and will be structurally funded as well. So I think that's an important point to make, that the funding we have seen for emergency response is one thing, but to continuously deal with health inequities, we need ongoing funding for trained experts in the field of social epidemiology, communication, and so on.
I would like to react directly, because I think what we have to keep in mind is that we could have known that infectious diseases are distributed unequally, but actually due to the beginning of the pandemic, what you have shown this morning, Claudia, it was thought that social epidemiology has nothing to do with infectious diseases. This was completely wrong, of course, and this was what we learned really, really fast, but we could have known it better before, because it's wisdom since, let's say, something like 170 years or something. So what I think what we should keep in mind is, yes, there is a huge inequality on the one hand, and there's huge inequity on the other hand, or both come together. And we should keep in mind that it's not only infectious diseases. It was me this morning with the NCDs, because what I said regarding the question, how can we get results from health reporting into politics? This is what I said this morning. If there's a really life-threatening disease, most of the time infectious diseases, because this is what we can see easily, then in my mind, politics are aware. But if we have diseases like NCDs that are really life-threatening as well, but you can't see it because it's not that quickly. And if we don't have surveillance of NCDs, likewise, we do have a surveillance of infectious diseases. This is a neglected point in my mind.
Definitely. Could I say one more thing? I would really love to add that infectious diseases are often not seen as lying in their own responsibility in comparison to NCDs. So in NCDs, there's a big story about, the people are just behaving in a way that makes them sick. And with infectious diseases, it's more Schicksal, destiny, exactly. And it's not. We have seen this with COVID-19. It's not destiny, but it's often regarded as not within the responsibility of the individual. And so it doesn't fit into the system of individual biological responsibility.
So even a stronger call even for having those considerations under one roof, also in an institute like this one, where it makes sense to bring those things together, and it has obviously worked, and it should draw on the future. You see, I'm a bit biased, but anyway, we'll come to that. If you have a question now, we can go ahead with this question.
No, more comment to. Danke. More an additional comment to what you were just discussing, in that, I'm a bit bothered by the distinction between, or, the communicable and non-communicable diseases. I mean, I know we have two departments, but we work more and more together. And this border between infectious disease and chronic disease is not a strict one. So, I mean, there's many examples, HIV/AIDS is turning, at least in the rich world, into a chronic disease. Hepatitis is a chronic disease. There's many more, and there might be many more where we find the infectious agent that causes or that is involved in the development of chronic disease in the future. So we should think more holistic in this respect also. Thank you.
Excellent comment. Really very much appreciated, I think. And I mean, yeah, cancers, we can talk about. There's so many infectious causes of cancer as well. So yeah, the distinction may be helpful sometimes, but it's definitely needed to bring things together. And we have another question. This works very well.
Yeah, adding on to that, I think we've just been talking about disease threatening our health, but there's also, we're talking about the social determinants of health, right? And that is not disease. And we also have climate change. That is not disease. I mean, it's a disease of the planet, so to speak, but it's not always just diseases threatening our health. So I think that also needs to change in our mindset to really look at contexts, structures, governments, policies, and everything that is happening around, not just disease or ill health affecting health of the people.
Right, thanks. I think, Stéphanie, you want to come in as well, right?
Yeah, I just want to react to I couldn't see the person in the audience who talk about the frontiers between non-communicable and infectious disease. I think it's an important point, very important, because I think we face to a big issue in our organization, because we are in silo, which pathology, and which is very difficult for the health inequities, that we need some an approach for populational approach and a determinant approach. And we are not organized in this way because of, I don't know, because of a political reason, or I don't know, but it's very difficult to work on a transversal issue as health inequalities when our organization are in silo, as you mentioned, non-communicable disease, infectious disease, and so on, as we had to work in one health issue. So I think it's something to do with the last comment on the climatic change also. So I think about we have to change or to modify and to adapt our organization, the organizational issue, in fact, of our institutions. So that's
Thanks,
my remark.
Thanks, Stéphanie. Very interesting point as well. So we're looking at future structures of national public health institutions. Please, yeah.
Yeah, no, thanks for the insights. I just wanted to basically follow up on the same question around, but more on the side of, work around aging. As people age with, chronic illnesses, like, for instance, HIV in the global north, and I think much more so it's an envisaged epidemic actually in the global south, that people are growing and aging with HIV, and this is an area that we'll talk a bit about, but I'm not sure that there's real body of attention to this area, which I think is something that is something that will probably hit us sooner than later. So I just wanted to hear your comments on this.
Well, we have the Center for International Health here present in the room, so maybe this is a topic that they in the RKA want to can take up in the future. But obviously, I also, you're quite right, there is an issue of a data gap again there. We don't really know how this affects populations in the south now, and we're just starting to look in the north in this. Anybody wants to say something, Heide, or?
Yeah. Hello. So I just wanted to ask mainly for you, Benjamin, because you are from RKI, but also in general, you've talked a lot about the data gap and about all the different silos. So my background is that I spent 3 years working for the Australian federal government with the Social Security Ministry and the Health Ministry, among others. We had someone seconded from the Australian Bureau of Statistics that was working a couple of days a week within the Social Security Department to enable data linkages. We then had someone from the Social Security Department seconded to the Department of Health to help with the data linkages between those as well. I'm just wondering if Germany has anything similar, if you've considered something similar, how much you talk to the other social policy departments if you're going to talk about the data gap in social determinants of health. Have you started those conversations? How much do you talk to each other within government?
You see, the reactions are a little bit muted at this point. This is simply due to the fact, I mean, this is, I would say, at an experimental stage in Germany. We are not any farther than that. There are certain, if I may just answer to this for now, and you can come in. I mean, there are concepts that actually focus on this. For example, we have this German national cohort study, and we are fighting, let's say, for linkage with, for example, social data from, be it the health insurances, be it the social service data, to get them together in that huge study. That would be quite a nice database to have, and that's ongoing work, really very much at the beginning. And there's some individual, maybe studies, also even the ÖGD research studies here, where this perhaps happens, that individual researchers, are seconded, as you said, and it really, but it's always often it's like establishing linkage in the first place without really, getting as far as doing linkages in some ways. So that's very early work, I'm afraid.
I can't talk for the RKI, but I can say something about the Public Health Services, ÖGD. No, there's the German Data Security Act, so there's no data linkage. It's at least not on the local level between social security data and health data. This is some of the gaps we still are suffering from, and there's some gap that we have to close. And I don't know if you want to add something, but it's the same for you. And I think it would be worthwhile to foster the engagement of politics in these terms.
Yeah, I would like to add something on that. I mean, data protection is a very big and serious issue in Germany, and for good reasons. But we've come to a point where data protection is sometimes blocking and making research not possible. And there's some voices who are saying, data protection is actually costing lives. So the situation in Germany is really very, very difficult, and it will probably take a long time, but this is something that we need to work on for sure to secure personal rights of people, which we all respect, but to at the same time, make possible necessary and important research. And there were several studies that couldn't be performed in time during the pandemic that would have generated important knowledge, but was just not possible due to data protection restrictions.
Yes, very important. In fact, I had noted this down for me as an issue that we might come to in the end, but now we've got it already. So here we go. Stéphanie? Please.
I just want to thanks for this remark, because I think it's really, really important. We face to the same problems in France, and I know it's the good reason, but the reality is that a lot of researchers don't want to continue because the delay are very, very, very long. We are about sometimes 1 year to have the authorization, and I think we can do better at maybe we can join at the European level for advocacy to have some more fluid, don't know fluid if more fluid system for public health purpose, because I think I'm agree with that. We should mention the life we lost because of our system. because of our bureaucracy. I don't know the term, which is a good term, but thank you for this remark. I think it could be an important thing to put together the country we face for this issue. And France is also. Maybe not the Scandinavian country. I don't know if you have some Scandinavian country in the audience, but I think they are more, it's more easy for them, no?
Yeah, I think that is probably general too, but still many other European countries definitely are affected. I'm not sure in other countries if the data protection is such an issue that it really prevents people from doing good studies, but here it does happen this way. I mean, it's quite so. Please, another comment. Oh, careful, occupational hazards.
I just wanted to react to that point. And so I'm Michelle Kelly-Irving. Stéphanie knows we work together. So just to make that point that to give you an example, during the COVID pandemic, I tried to get data together from this on the social environment in France using an insufficient ecological measure, such as the one mentioned by Stéphanie, and to get the health monitoring data on testing and so on. And the data arrived 20 months later when my project was finished and no longer funded. Right. So just to give an example to reiterate what our colleague behind said, it was too late. And it's insufficient. But my point really is there is no solution in sight. And yesterday we did have a comment by our colleague from Norway who was trying to shame Germany into doing something about this problem. The same problem is true of France. Those are the two biggest countries in Europe. 80 million for one, 60 million for the other, but we don't have the data properly integrated and in a way that's ethical and safe. And we need to do something about it.
So I hope somebody's taking minutes of these important remarks, and the resolutions is almost we're getting to, but we have people from the chat coming in, please.
Thank you. Yes, this is a comment. Rather, and this participant is pointing out that there is, of course, a long history of, there are historical reasons usually why certain issues are held very near and dear and are maybe a little less easy to do, as is the case for data protection, and that it is very important to think about from the patient's or client's perspective that you have to win their trust and really also show them and convince them that they should give up their data to you. So maybe that's a little bit of another nuance that we can add to the conversation that we are having right now.
Yeah, thank you. Very important point. And I think research institutions usually have a good start, because when we look at our studies and our patients, I'm sure it's the same with RKC studies, the data protection papers that they have to sign, they are very long, but they're usually not the problem. People do sign them. Once they have gotten that far as, considering in the first place to take part in the study, it's not the data protection sheet that stops them then. And then we see it in the NARCO also very high, agreement to this super long paper that, clarifies 110% of everything you didn't want to have clarified. So.
I had a question or more or less a comment and more directed to Stéphanie, because I think in the French system they have what they call the carte vitale, which carries the insurance information as well as a track record, if you want to call it that, of the treatment processes. I'm just wondering whether that's enough data already that can be used in one way or the other, and whether you have access to that, and how that would compare to other European systems in a way that anywhere you go to a doctor, for whatever reasons, there's a track record, and somehow that can be useful in all this research that we're talking about. Thank you.
Well,
yeah.
I think it could be an important point to use we have the SNDS system, which is the national system of health data in France. But as it was mentioned, it's not so easy because it's not very precise data on social determinant. In fact, we have only the couverture maladie, so the health insurance. So it's not enough. In my opinion, it's not enough because we couldn't measure the social position at individual level with only that data. But I think we should improve because it's not sufficient for many social data. And for instance, actually in a hospital system, we have at Santé Publique France, we monitor all the daily data from the hospital, emergency unit and so on. So it's very big data issue and very efficient to measure some impact of everything, in fact, the flu, all the epidemics, but there is no social data except the health insurance. So in my opinion, it's not sufficient. We need the origin, we need economics data, we need employment and some housing. We have more data on structural social determinants.
Thank you. Please.
Thank you. This is digressing from the data question. So if there are more data questions, then I think that should take precedence. But I'm going to, and probably this is also a bit provocative, but I'm just taking the opportunity of so many public health professionals being here and wanting to open up some reflection about where we as public health community have failed. So as public health, we really talk a lot about gaps in evidence. We talk about some of the successes, which are largely to do with sort of clinical advancements and what we have made progress on. But I mean, we've also heard today about HIV/AIDS. It's almost an outlier in all that we call for community participation. It was backed by the largest embodied health movement and social movement that we saw. It was very well funded. It has been one of the better funded and the best sort of three infectious diseases that have been funded by a lot of global actors. We've been decades since we had discoveries, since there was acceptance of HIV/AIDS as a problem, and we still have we're not even close to coming to the targets. But I'm just using that as an example to say what, according to you, is underpinning the failings of public health.
Yes, we are getting into matters. Right. I'm the moderator, so I'm going to give it to you. But Dagmar, maybe you can save me here.
Okay, very good question. I think, well, there are several points that I would like to mention. One thing is that actually we have a lack of cooperation within Germany. There's some cooperation, of course, between some institutions, but this could be much, much better. We really could have some kind of a board on equity, for example, or something else. So good cooperation is lacking. I think the next point is community-based research is really not really common in Germany. We love exactly to have studies. We're happy that we now do have studies. Claudia explained this morning that for a very long time in Germany, we didn't have any epidemiological study. And honestly, this started because of myocardial infarction of the high-income groups. This was the point when epidemiological studies started in Germany, not because of those in low-income groups. And so this is a very long history, and it was very slow. But community-based research, this is what we only have very seldom, not in all areas, sometimes in prevention and in in my expression, I think sometimes it's really hard to get people do it, just to get into contact, to live participation and not only talk about participation. And this is the whole discussion on nanny state and paternalism in health. So this is the second point. The third point is that we still have sometimes really segregated field, that health is a really medical question and the question of medical doctors and not the question of public health professionals and not at all the question of the communities. So this is, sometimes we have medical research, we have some kinds of public health research, we have social science, and I loved the expression from Terje yesterday, we bring social science into public health. I really love it because this is what I think is really necessary. We do have to bring those issues together. And the last point I would like to make is that we do not make use of the multi-professionality that we do have in public health. We do have a multi-professional field in the public health services, but still we do have some kind of hierarchy and not using all the knowledge which is present.
Here I would invite comments from the, we have comments from the chat, right? And then maybe Katja.
I feel like I'm skipping the queue because this is not a comment from the chat, it's actually a comment from myself. If that's okay. We can save this for later. I would really love for the discussion to also move a little bit more in the direction of policy, just to link it back to the overall topic or theme that we had for this discussion this afternoon, which was why should we care about health inequities as a National Public Health Institute? And the associated follow-up question then is, how do we actually anchor that within an institution? And obviously having the research units that do the work is one way to do that. But I wonder, and this may be a little bit of a professional bias because I have a background in international politics, so I think about policy then. Is there a way, or what are the thoughts on policy in order to guide the work that, or maybe also the subtle advocacy in some ways, maybe that a National Public Health Institute can do? And do we see a role for that? Is there room for expansion in RKI to have more of that, to drive that work?
Yeah, right. We'll take this. We note this that we need to think about this, especially when we really talk about the role of the RKI, as you allude to, and we want to do this, and we carry on in a second. But maybe we'll ask Katja to come in. You said you would.
Yeah, well, it goes in a similar direction to yours and to Anu's comment. So I've been thinking about the point about NCDs being less visible than the CDs, and I think that might be true on the one side or to some extent, but I think the issue is not the visibility. The issue is, I mean, HIV is not visible as well, if or to at least to some extent, at least until people get really, really ill. So I think the question is more of a political interest and a political pressure around this. I mean, the HIV pandemic is a long history of community organizing versus systematic exclusions, political disinterest, and there's been the community itself, the gay and queer community, has been talking about health apartheid. So, and the efforts and also the small successes or some successes which has been achieved are basically based on the organizing and the political pressure, I think, within the communities, but also with the strategic networking with people who are obviously maybe also here in the auditorium now. So I think this is something we have to put our focus on. This is also what Professor Mugabe was saying today morning, I think also, that it's a question of political will, not only about the evidence or about community engagement in whatever research projects we try to implement on someone. And I think, so this is the question now, getting back to the question of the podium today. So our institutions, I mean, we obviously have some limitations, but we all obviously have some possibilities where we can try to go back and forth sometimes.
and to organize strategically and to do the networking, the strategic communication, and not only to go the known paths, you know. So we have to open up, I think, the idea of political pressure. How can that be built on? Yeah.
Right. Clapping hands there. So I would say you're mentioning issues around cooperation, networking, getting stronger together. So I have another question written down here that I was bringing along, which goes in this direction. So I'll just pose it and then we see how far we get. Because obviously in Germany, but also I'm sure in France and elsewhere, we have numerous institutions all across Germany basically working at local, at communal level. And they have a clear focus on reducing inequities and supporting marginalized populations. For example, the Landesvereinigung für Gesundheit, or the different names they have in different states. So the question would be there, how much networking is possible, or how much networking is happening? Which kind of guidance and support can actually a national public health institute give to such local and regional institutions? What is the feeling there? I mean, I can perhaps ask Ben again to come in and see what he thinks, how much of that is, possible, but also how much that would lead to a stronger network, even that then, strengthens also attempts into policy making, perhaps.
Yeah, thank you very much for this really important question. And I think you at least partially already answered it. So we are talking about networks. But what might be the role of a national public health institute? So we should perhaps become a little bit clear what is a national public health institute, and that's an ongoing discussion, I would say, and just a recent discussion during the last 20 years, perhaps, I would say. And just recently, Janfi put a statement out there defining a national public health institute, which is, I would read it out. A National Public Health Institute is a government agency or closely networked group of agencies that provide science-based leadership, expertise, and coordination for countries' public health activities. So I think I'm reading this as a really acknowledgement that we can only think in networks with different stakeholders in public health, and the National Public Health Institute has a responsibility to be a hub and to take leadership in organizing these networks. And I think we are just at a starting point with this, and we are trying to build new networks. COVID-19 was an example for this as well. But we have to continue in building more networks and cooperations, and I think that's the responsibility of the National Public Health Institute, and we will see how far we will come. But there are so many aspects. We have discussed it today in this scientific roundtable with Michelle as well, that all these tasks around how can we get from fundamental research to interventions, and how can we evaluate them, and how can we put up pressure that are tasks which needs experts. We research scientists are not trained for doing political communication, for example. So we need a strategy how to which data we have to analyze, in which forms, which measures we have to take. For example, measures who are more obvious for politicians should be integrated in health monitoring. We have to establish a continuous health monitoring, public health surveillance system that also includes these measures, and we have to cooperate with communication experts, trained international politics, and I think we are just at a starting point, and I hope that we will come further in building these networks and being their hub for these networks.
Thank you, Hajo, for the question and bringing the Landesvereinigungen, so associations, networks for health promotion at the state level into the discussion. We do have a strong cooperation with them because, of course, during the training, it's really helpful to have them to bringing some more of the issues that they are caring about into the training situation. And the next point is what we have to think about between National Health Institute training and local health authorities is how to bring evidence into practice and how to translate research results from research into practice, and also on the other way around to have questions from local health authorities bringing into research or prove doing a check if there might be some evidence or could be raised some evidence. And finally, of course, we have to think about policy and raising political interest for our issues. But I'm doubtful whether it's possible to wait for that. So maybe we should I come back to the academic activists. Maybe we should start with it and bringing evidence into practice and working on that to work on the issues that are obviously necessary.
Okay, thanks. We have Stéphanie here, and then
I just want to react from 2 points. The first is academic activist. Yes, it's a good term. Maybe I can share an experience about that. I think we used during the pandemic a tool from Canadians, the National Institute of Quebec, because we have the special relationship with Quebec, you know, and we used knowledge mobilization. And I think it could be a very useful tool to have a leadership with policies, because we have in the same level the actor from the field, the researcher, and the stakeholders. So it's to share the theoretical and evidence-based data with the experiential data from the field. And so you can integrate these two parts of the science. And so it's very useful for the policies makers, in fact. So this is the first point. The second one, it's about the failure, why we fail during the crisis. And I think I agree with all the points the colleagues are mentioned, but I would add two supplementary points. The first one is the trust. I think we have to work on trust. And of course, participative approach is one of, it could be one solution. We have in Santé Publique France a committee which for the dialogue with the society. So it's kind of an approach to have the feeling from the field. And I think it's very useful to measure the lack of trust the people had on from the institutions. And so we have measured this during the vaccination hesitation of vaccination strategy in France. We are the country, we are the worst vaccination trust, in fact. So we have worked a lot about these topics. And the second point, I think it's the training, because I think in the public health field, we have a lot of data scientists and very specialists, but we lose the spirit of the public health, I think. And so maybe we have something to do with that for the young generation. So that's all.
Behind you. There's a microphone for you.
Thank you. Last 2 days, I'm very, very impressed with the depth of thinking and analysis around social inequity in health, not just at the level of Germany, but also more widely. And I see in my interactions in the last 2 days, passion in many young researchers in RKI about the field of public health. And I'm wondering whether at the end of these 2 days of colloquium, RKI as an institution would be thinking about doing something about the knowledge it has developed on social inequity? Or will its role be limited to just producing knowledge and saying thank you? Because as public health professionals, improving the lives of people is a commitment we make as professionals. And that commitment precedes our commitment as a good employee of RKI or a good standing of RKI in German and international context. It's a valuable institution. It's an institution that can play an important role, not just for Germany, but for wider connection of committed professionals in public health. And given the crisis that COVID-19 has demonstrated, more needs to be done in bringing about change than just understanding the problem. So that's what I wanted to pose in front of you.
Thank you very much. I think you hear that there's much sympathy for this position. So another issue for the organigram of the RKI to see where this fits as a...
Yeah, thanks. I couldn't agree more. And actually, my remark adds on quite nicely to that. One thing that always bothers me when I read the guiding principles for the German Public Health Service is the word sozialkompensatorisch, which basically means to compensate for problems that arise from elsewhere. And I think maybe it's also a nuance that we can add to the discussion. Whether or not public health professionals' ethos needs to change from something that is just reactive and kind of treating symptoms to identifying and curing the actual problem, which I think lies in the structures that we live in and was alluded before earlier. And public health in that sense needs to become more political, as what Robert Koch said. And I think we had that quote in the beginning. So that's my remark.
Thank you.
So I would like to share with you two comments from the chat. The first one invites us to broaden the scope of our discussion, and this is a slightly abridged version. So we see increases in wealth, which have made humans live healthier and longer lives, but they put the ecological system and climate in danger. And so this participant suggests that we should also talk about limits of improvements for human health in favor of other species' health and planetary health. And so asks whether we should consider in addressing inequities among humans to really focus on disadvantaged groups only, and maybe even to limit investing in the health of groups that are already very advanced. And another participant is just inviting us to take note of a German collaborative network for equity in health, which is a structure that is improving equity in health in Germany and supporting health promotion for socially disadvantaged groups. It has been funded by a National Health Institute, the Federal Center for Health in Cologne, and it disseminates good practice in Germany in this working context. So all the experience gained in good practice projects and programs that refer to social status-based health promotion. And they also offer training of stakeholders. So this is for people who are active in the German context, may be interesting to be aware of.
Yes, thank you. I think, again, important points to make, and obviously, I mean, putting a bit of a wide umbrella towards, looking at human health. Let's say you mentioned planetary health, and how is human health positioned in the overall scope of things. It's getting more complicated, but at the same time, these are the things we are needing to look at in the now and in the future. This is just the way it is, and still, we are at a National Public Health Institute. You won't be saving the planet from this auditorium here. That's also quite clear. So we need to also flesh out very much what can be the particular contribution that the public health institution like this one can make, and also, see where the particular strengths lie and where one needs the alliances and the networks. That would be my little comment at this point, but I hand it over to you.
Thank you. And I'm so glad the last few questions and how you also responded to the question I was raising and talked about the intersectorality and working together. And I think for me, my reflection of where we've really failed is that working in silos, and as public health professionals, just interpreting and reinterpreting data, the limited data that we have, has almost distanced the public from the and eroded the trust of public in public health. And in order to change that, I mean, the last 2 days have been really phenomenal in talking about community participation, changing praxis. So the question is also, have we been asking the wrong questions? And also, have we been asking the right questions in silos, in wrong places? So working intersectorally, but generating evidence that can then inform policy, but also generating questions through policy, but also through practice. And I use the term praxis as well, reflecting on our own practice. How can we reduce the gap between public health evidence and public health practice? And just the last comment, really, communities have to be at the heart of it. And what you have unleashed in the 2 days through this program is a massive responsibility, because the audience and the researchers that Rajesh was also mentioning are really enthused about these ideas, about changing epistemological hierarchy, changing the ways in which we produce knowledge, listening more to the communities, not only limiting ourselves to the data that are being collected routinely. So I think that's a huge responsibility and for RKE to take forward, and for communities to be at the heart of this agenda. As a lot of activists have talked about, nothing about us without us. I think that's the principle that public health needs to come back to. Thanks.
Please.
Well, I think it's a very interesting, fascinating discussion, and I want to come back with my question to a little bit something Dagmar said and Stéphanie said, and then link this to what Anisha said. And Dagmar said, taking the science into practice, and Stéphanie said, we need to build trust. And when I was a kid, I learned in school, the proof of the pudding is in the eating. How can we show that what we do in the practice then actually works, and by doing that, building trust? What epistemological changes do we need to push for this? What did we ask the right questions or the wrong questions, or did we accept the right evidence as evidence, or are we looking in the wrong place? And this, I want to link a little bit of what can we do. To what extent is a National Public Health Institute on the one side, the institute that gives evidence and supports policymaking, and to what extent should, in a constructive way, other areas of academia look on how to look at the things that are done and evaluate the actions and look at, in a quantitative or qualitative way, how good the policy advice and all of these things is, what we can learn from it. Because I think that one of the things of mistrust is that some people say, this is the only right thing, and some people say this is the only wrong thing, and things like that. So what would be the role of academia in this? What would be the role of a public health institute? And how can we show that we care?
Minor questions to be discussed here. No, yeah, it's obviously yeah, to boil it down again to no, yeah, okay. Again, please. There's a comment coming in. Stéphanie, please go ahead. We're not hearing.
You're muted.
Thank you for this challenging point. I appreciate the reflection, because I wonder to share you that one thing I think we can improve, because in my institute, for example, it's a French example, but I think we have a focus on individual behavior, and that is not really ethical. I think it's an ethical point. So we have to focus on structural determinants in order to not ask the wrong question, as you mentioned. We have to highlight the structural determinant of life, of health, because the policies will be not really taking account, but they didn't ask. We don't know. We didn't know if we are producing data on the effect of structural social determinant on health. So we can focus the marketing, the social marketing and communication only on individual behavior, but also on the environment which have produced this unhealthy behavior, in fact. So for example, we have the Nutri-Score in France. I don't know if you know that, but I think it will be an interesting story to tell, because I think we didn't fight against the good target, in fact. In fact, for example, I think we didn't take into account the lobbying, and in particular the agroalimentary lobbying. And I think this story is very important to mention, because we have to learn a lot to take into account the One Health or planetary health, because the health inequities have something to do with the domination, and we don't talk here of the north country of the north on the south countries and so on. And maybe if we investigate this point, I know it's a challenging point, I know that, but I think it will be more useful, and we can also gain trust for the population, because this is the real issue, in fact, when we talking about lobbying and so on. We can just say to the people, hey, you should eat more than 5 fruits or vegetables by day, if you don't take into account all the socio-ecological system, in fact. So thank you for your remark. I think it's challenging, but it's important to share.
Thank you. And Heide, please. Yes.
Hi. I'm listening, and I think we have these complex issues, and we are kind of overwhelmed often by complex issues and by the complexity. And I think we are also a bit overwhelmed by how do we engage with communities, because I think we all acknowledge that's important, but the question is, how do we do that? And Claudia said, we actually need to talk. And then if we talk, it gets better. And I look at France, and I'm sometimes a bit jealous, because they have this very centralized system, and we have a very federal system in Germany that's very dispersed. And I think we often complain about that. But I wonder if, with regard to the engaging communities, it can be a strength. And maybe that's a question to you, Dagmar, particularly. Can we use the ÖGD better, the federal level and the local level, to really engage communities? And where I'm coming from is we conducted a study on risk communication during the pandemic, and we found that one of the major criticisms of how Germany responded to the pandemic was not to involve local communities and not to involve existing networks in the risk communication and in the hearing what were the problems in the measures that got implemented. And we have this complex system of federal level, but we also have these ÖGD structures where people actually are really closely in touch with people. And is there a possibility to actually use that to strengthen participatory approaches?
Well, let me start like this. I don't like to use them. Yeah. But what I really like is to have participatory research all together with colleagues from the local health authorities, because this is really fruitful. This is what we are doing at the Academy. Our research is really focused on local health authorities, and we have kind of local health authority based participatory research. It's a very long name. This just came into my mind. In German, it's a little bit easier, but this is what we are doing. And of course, local health authorities are entitled to have participatory approaches with communities, and they are doing it. Not every local health authority, of course not, because there's something like 378 local health authorities, so not every local health authority will act like it. But of course, exploring together with the colleagues from local health authorities how we could start with community-based approaches would be, in my mind, a very good way to get into the communities and to talk with them. And so it's a participatory approach. Sorry, it's okay.
Yeah, I would like to come back to the topic that has been mentioned a couple of times, but we didn't go into depth into climate change and the planetary health crisis that we're facing at the moment. And we as RKI have been occupied with the question, what is our role in the field of climate change and health? What can we do? What is the frame that we have? And maybe even the responsibilities. And I think as part of that, we need to also think of the question, what is our role as a National Public Health Institute in climate change and health inequities? So I think these two need to be thought together either way. So when working on climate change and health, we need to take health inequities along. And when working on health inequities, we need to take climate change along. And I think these are two intersectoral and cross-departmental topics that need to be taken along all the time. And maybe to you and everyone, the question, how can we integrate these two topics that are running through all other topics as well, right? Like they're both the same complex problems that need to be thought together, and then together need to be thought with all the other health issues. Yeah, I don't know if there's an answer to it, but I think it's an interesting question.
Right, I can give a first short impression here. That maybe you, but I mean, these are questions really of that we learned during the pandemic. Obviously, that these are kind of overarching issues, and equity came in earlier than some people saw it, but it was there from the first day, basically. That's quite clear, and that's the same with climate crisis, because we all know that people suffering from climate issues will be again the same groups that usually suffer from things that affect populations, and this is that's where we are. So I think it's actually not something very new. It's probably we need an integrative approach really to say these are the challenges that we have in the future, and the RKI has had other problems to deal with, cholera and whatever in the past. Now it's a big other and lasting topic that will be there. And I mean, this is obviously the issue, how, where does it all fit in? And I think, again, it needs to kind of be of an integrative approach. That would be I'm a moderator, so I'm not giving an answer here. So just a comment on, please.
If you don't mind, I would like to join in on this type of questioning, which I raised yesterday also in my talk about how we're not going to solve or get anywhere close to dealing with the climate crisis if health inequalities aren't dealt with, much like your comment about HIV. So we've talked about participatory approaches, but now I'm going to bring it to the top, the decision makers, the people who make the decisions. And to what extent can public health institutions such as yours, which are affiliated to those government institutions and funded by them, to what extent can you challenge them? To what extent, because these are political questions. And for example, something like the commercial and corporate determinants of health, which affect things like the Nutri-Score that Stéphanie brought up. So like the agro lobbies and so on, those affect the question of equity in health and the effect, of course, climate change. And there, what can be done? Are you the right people to do it? Because are you too close to the people who are making the decisions? And if so, it's up to someone else then? Is that what we should conclude? So What do you think?
This goes very well with my storybook, because I was going to move towards, what barriers are actually there for a national public health institution to deal with those issues around equity, and in extension also with crisis issues such as the climate crisis. So let's talk a bit about barriers. And you mentioned one important, very open question, I think, but she's got the solution, please.
Not really. Okay. Katja's, we started later, so we have a little bit of time. Okay, so I think it's a really important question that you raised, and I think that climate change is one of the, it's the main topic of SDGs, and we wouldn't solve the problem if we can't, if we don't move beyond inequity. So this is quite clear. Second question, or second point, decision makers, at least there is some movement on the national level. So the Ministry of Health is kind of active. There's some kind of paper that was published in the end of the last year, and many institutions in the health in dealing with health in any way were committed to think about and doing some trainings and so on. And but what always is missing is a point of equity. And this is the same what holds true we have in Northern Australia, where our academy is located. There's a resolution from the Federal Health Conference, which is an instrument, political instrument. There was a solution on climate health, and but still the same thing, equity is missing. But now they started to initiate a working group, and well, I'm a little bit hopeful. Ben was hopeful in the beginning, and now I'm hopeful that we could place this topic as we are invited. So a little bit.
Ben, any comments on major barriers to advance equity?
Major barriers, I think we have heard about a lot of them already. I don't want to start again with data, for example, but I think it pretty became clear that what we are missing is an overarching framework and more collaboration on different levels, and a fundamental change in our consciousness as public health researchers, and perhaps a little bit more moving to activism, because I would raise the question as well in the case of climate change: who are we addressing actually, and who will be the people who will do the change? So I think the problem we have is the problems of influence and of consciousness building as well, and with communities, together with communities, and to getting a little bit more back on the ground to grassroots change, perhaps. That would be my solution, perhaps, how we could deal with this. But I'm afraid that these are processes that will take a really long time, that perhaps we don't have anymore, and so we have to be active on different levels. I think that's influential and essential for at least having some influence in the future. And recognizing health inequities or social inequalities as main drivers of climate change, I think, is essential as well. And that doesn't mean that we are talking about restricting healthcare services for anyone, any human being. I don't think we have to talk about these ideas, but we have to talk about who is responsible for the majority of the sequelae we are seeing from consumption, and there's huge social inequalities in that, and these must be addressed in the future to because like the Mugabe said, social inequalities are deepening, and perhaps in this case not prolonging crises but shortening them. That would be worse in this case. And but all this can't be done by a National Public Health Institute, but is a that's a task for the whole society and for all the organized civil societies, and we have to cooperate with the organized civil societies more as a public health community, I would say.
Right, this is almost the final word, I would say, but we have one last comment from Jeffrey, and then we'll move to the end if that's okay. Yeah.
No, I just I have a comment that it's still from more or less the question, can we use the local public health services? And I would agree with Dagmar, we shouldn't use them, we should work with them. And I have it came more or less in regards to the COVID pandemic. We have a network of approximately 80 health monitoring workers in the local health department that has developed more or less as a self-help group. The people doing health monitoring in the local health offices are generally the only person who's sitting there who has more or less an epidemiologic background and who can do this type of work. And I think there would be it would be a very good win-win situation. The local public health offices, the health monitors, they have this data gap, data equity gap that we've been talking about the last 2 days. And I think that is something that the Federal Health or the Robert Koch Institute could help with. Maybe we won't be able to do it totally aushebel the data protection situation, but it would be good for the colleagues working in the local health departments to at least have better data in regards to the different German word Betroffenheit, the different ways the people living there are affected by climate change and also by other health situations. And we have this work group, health monitoring. We have there's a big interest in climate change and health monitoring. We have, for the German Society for Social Medicine and Prevention, we have a session this fall in Hanover regarding health monitoring.
So that's the commercial block. Please come to the conferences. Jeffrey, come to the end.
The interest on participation, as I said yesterday, the people sitting in the health departments, in the local health departments, are the people you need to tie in when it comes to short-range change. Because
that's I think a very good point.
Something we had it from the Robert Koch Institute.
Yeah, and so that really shows networking is the key at various levels, which is a challenge, I think, for the RKI definitely to build up these networks and use them is quite clear. I mean, has not always been the strength as an outsider, I would say this, so that needs to be strengthened and done much stronger with the question, how far can you take this, which, also relates to your official tasks that you have and your scope that you have. And the final word would be we need alliances, we need support, and who else can support us better than artificial intelligence? So I asked ChatGPT, is this equity issue something for national public health institutes? There's a long story. I just read the one-sentence conclusion. In conclusion, equity is a vital consideration for national public health institutes. So just finally...
Many thanks, Hajo and panelists. So before you leave now, I have unfortunately 3 more things to do, or 4 even. First of all, again, thank you for your discussion and your coming here, and all of you coming here and bearing with us all the 2 days. There was supposed to be a wrap up. I think this is very difficult. So We started with what is known. It's a very complex issue. There are a lot of studies that demonstrate, of course, a clear impact on wealth, education, other determinants on health, life expectancy, and so on. There is still a lot of missing. For example, data in Germany on mortality merged with social economic factors, so a lot to be done. It's a very complex issue to measure, we heard. The inequalities, the migration, it's so complex, it's not easy to measure, to understand. But we have to leave the ivory tower. We have to start listening and to start more participatory research, we have learned. I think we should not be sorry that the pandemic is over because even if the focus maybe shifts away, because we also learned how much the pandemic worsened the problem actually. So what to do, what is needed to do for us, for the society, it's very clear, to become more equal. But it's not so easy. And what's our role of public health and public health institutions? We have to, I think that's also clear, get more engaged. There is a moral imperative, we heard many times, that we have to leave the ivory tower again, that we challenge and maybe also change the game of science we are playing. And that means we have to also maybe change our own mental and scientific frameworks and open up. We'll have to learn from AIDS and from COVID-19 pandemic. And there is a lot of offers, a lot of collaborations. Everyone talked here, offered, also us at RKI, a lot of help, cross-sectional, cross-national, interdisciplinary collaboration. So there is a lot to do, not alone with the public health authorities, but also other actors. And we need to improve our knowledge, of course, in the scientific field, but our knowledge is enough already to act on. Surveillance is data for action, and actually it is enough already. So while getting more knowledge, we start acting as maybe academic activists, reach out for population and politicians, and give the health of the underprivileged a voice. So that's probably what public health main issue is, to combat discrimination, race, ethnicity, gender, sex, religion, migration status. We are also public stakeholders, so we have to act, but it's a health and all policies issue. So we cannot be alone there. We have to get some partners from other fields as well. So this would be my very brief summary.